Good morning, everybody, and welcome to the July South East Perinatal Mental Health webinar. Just as people join, can we just give a reminder to everybody, our usual housekeeping. Please can you keep your lines on mute unless you're speaking or asking a question. Also your cameras off unless you're presenting or until we have the questions section. Please do raise your hand to ask questions and also put questions and comments in the chat box. It's always nice if people want to just put in the chat box who they are and their kind of what organisation they're representing so that we know who's on the line today. That would be great. And just a quick reminder that obviously we're recording the webinar, so those that can't make it today can watch it at a later stage. Okay, thank you very much. So without further ado, onto our agenda for today. So our focus for July's webinar is neonates and perinatal mental health. We'll kick off the webinar as usual with a bit of a national and regional update and some resources from Jenny and myself. Then Vicky and Holly are going to give us an introduction to Bliss and to talk about working support families. Then Jacinta and Siobhan will be talking to us about developing psychological services to support infants, parents and staff on neonatal units. And then it's a great pleasure to have Manesh Kashu with us today. So Manesh used to be our clinical lead when we worked in maternity back in the days of Wessex. So it's lovely to have him join us today. And he's going to be talking about dads within neonates and improving the father's experiences of perinatal care. So a great packed agenda and we hope you enjoy it. Okay, so bit of a national update to start off with. So firstly, and probably quite key, is our August webinar that was scheduled for the 24th of August is being cancelled and is being replaced with a webinar on the 9th of August. So this is a webinar that we're putting on as a kind of ad hoc edition in conjunction with the National Perinatal Mental Health team. And the focus of that webinar is working across the perinatal mental health pathway to support delivery of the NHS perinatal mental health long-term plan commitments and ambitions. And it's really going to have a focus in terms of supporting systems and commissioners with understanding the extended and expanded cohort of women that perinatal mental health services should be seeing. So linking up with the access targets. So as I say, that's a webinar that we're running in conjunction with the national team. You do need to register for the webinar. So unlike our normal monthly webinars, where you just get the invite and you rock up on the day, we do need you to enroll for the webinar. The link is on the slide. And also if you contact us on our normal generic inbox address at the bottom of the slide, then we can send out invites or the link to you as well. And what we're encouraging people to do is if you register for the webinar, even if you're not able to attend on the day, then you'll get sent the slides and the recording following the event. So if you're interested, even if you're not able to join, please do register. The webinar is going to very much focus on reflections of the lived experience of women within the perinatal period, understanding the clinical cohort of women, hearing the case for investment, hearing from a specialist service, and also key system learning for implementation. So it should be a good event. So, and there will be a cancellation coming out for the 24th of August diary invite as well. So I just wanted to touch on the Start for Life vision, because there's a lot of work that will be happening around this area over the next couple of months and going forward. So the government published the Best Start for Life and the vision for the first 1001 critical days in March 2020. And there were a number of action areas ensuring families can access the services they need, so seamless support for families, a welcoming hub for families and information availability, also an empowered start for life in terms of the workforce, continually improving the Start for Life offer and leadership for change in this area. And there is work that's going on, and we're hoping that we'll be joined in September, and we'll have a particular focus on this going forward. But just wanted to highlight that to you in advance of the September webinar. Just an update in terms of maternal mental health services from a national perspective. So there are now 25 maternal mental health services that are now operational and accepting women onto caseloads. And the national rollout, of course, started in April 2022. There was the 4th implementation event that was held in April, and all the resources and the recording and the slides from that are available on the collaboration platform. There have also more recently been a couple of webinars. So there was a webinar focusing on collaboration between maternal mental health services and perinatal pelvic health services, and also one focusing on supporting women who've had their babies removed at birth due to safeguarding reasons. Both excellent resources, excellent webinars. So please go to the NHS Futures platform to have a look for them. Can I just ask people to put themselves on mute or cameras off if you're not presenting? Thank you very much. So the really important thing is that the Maternal Mental Health Services dashboard has now launched and is available on the Futures platform. And there's ongoing work around that in terms of data quality and reporting. But please do go and have a look at the dashboard. It's a great resource. Also, there's the finalised 2022-23 assurance template, which will be jointly completed by both mental health and maternity colleagues. And the ESME study that's been going on in terms of the evaluation of the maternal mental health services, the phase 1 part of that study is due to be published soon. I believe it should be autumn, so that will be, and we're hoping to get them along as well to one of the webinars to share the evaluation as well. There's work going on with the Maternity Consortium on a project to ensure equitable access to perinatal community mental health services and the maternal mental health services. And obviously the national team are continuing to support sites as a regional team. So do get in touch if there's particular areas of focus or that you would like to be in future webinars. Okay. Other updates, so and forthcoming events. So in terms of the flexible ambition around psychological therapies, there is going to be a national webinar that will be held on the 28th of September to share key messages and best practice, and invites will be going out for the national team regarding that in the coming weeks. And then also just an update on the national benchmarking survey of 0 to 5 mental health services. So that was a survey that we shared and we talked about on this webinar. The closing date was back in June, and there was a slight extension to that for specific requests. But the timelines now going forward is that the national report will be provided to the National Perinatal Mental Health Team in September. Then there will be bespoke provider reports that will come out to yourselves to be circulated in October. There will be regional reports in November, and then the plan is to have some regional findings events in November, December. So further details of that will follow. So just a plug, I've mentioned it a couple of times already this morning, but the Futures NHS collaboration platform is a great resource in terms of all the national information for perinatal mental health. So please do go and have a look there. As I said, the Maternal Mental Health Services dashboard is now available on that platform, but also if you're not already signed up to it, please do get signed up. It's a great resource. So on to web beds. So some of you on the call today may well have joined us last week. We had the web beds migration meeting on the 19th of July. So thanks to all those who attended. We had representation from the mother and baby units from across the country. And this is the web beds is obviously our bed availability tool that we use for perinatal mental health mother and baby unit beds across the country, and that's in a process of being transferred over from ourselves in the South East mental health team over to the national team and the CSU. And so we had the initial meeting last week in order to look at the functionality, making sure that it remains as near to the existing kind of format as we have currently. But there are future meetings taking place over the coming weeks. So key stakeholders involved in this process will be invited to the focus meetings to ensure the smooth transition. And then it's due to complete and WebBeds will transfer over in September. So for those of you within the mother and baby units, there'll be further information issued regarding that. For those of you that refer, it shouldn't make a difference. And I'm now going to hand over to Jenny, who's going to go through a bit of our training and resources.
Good morning, everybody. The first few slides I'm going to talk to are about our training, and just for our national colleagues on the call, just a reminder that these are actually for people in the southeast region. So if you're not within that region but want to know about training opportunities in your area, do get in touch with your own regional team. So the first one we wanted to highlight was Make Birth Better, the birth trauma training. So each of the MMHSs has 25 places for this training, for the MMHSs to agree who will be on that cohort of training, and then they are going to collate the list. So don't come straight back to us for individual requests. That's the message with that one. But I think that would be a really great training for the MMHSs. Next slide, please. And again, 5 to Thrive is a reminder that we want to train trainers. So there will be an email coming out to everybody that went on to be a champion. Remember, these trainer posts are fully funded and will skill you up to be able to deliver that training in your own area. So definitely encourage people to come forward for that one. Next slide, please. We've still got places for cultural competency and safety. This is a 2-day course and you can see the dates on there. So please apply for this and make sure that we make the very best use of these funded places. I think that's going to be a really good course because it's another one that's looking behind cultural issues to look at attitudes and bias, and I think that's going to be a really good one for our staff. Next slide, please. The regular push for the Gypsy and Traveller cultural awareness training, as you'll all know by now, we've got a year's licence for this training across the southeast for all disciplines. You can find it on the Perinatal Academy, so please do encourage your staff to attend. Next slide, please. Moving on to resources now, on the left here, we've got the very, very recently published Women's Health Strategy, which I think everybody working in the perinatal space ought to make themselves aware of. It's got the government's 10-year ambitions for this area, so this area of health. So I do encourage you all to have a look at that. And then on the right here, the NCT are doing a survey currently for people that have recently given birth, looking at their experiences. So that's one to maybe encourage your patients to join, and the links there that will come out with the slides. Next slide, please. Okay, so on the left here is a little animation. It's just over 5 minutes long, and we have shared it within our clinical perinatal mental health services with the service managers, and we've had feedback that it's been really valuable. It's just a short animation looking at all the changes that the NHS are going through currently, particularly the move to ICSs, ICBs and provider collaboratives. So anybody that's interested, I would say that's really worth a look. And on the right here, we have the launch of a new short film, which was a collaboration between the Institute of Health Visiting and the PATH project. And congratulations to Solent Health for being such a big partner within this film. So it's a short film which really sort of explains the role of the health visitor, and I think it would be very valuable actually on induction for new staff, because we have a lot of new staff coming into the workforce who may not be aware of the role of all the different stakeholders within this space. So I think there's lots of uses for this film, but I think that would definitely be a good use to introduce new staff to the health visitor role. Okay, next slide, please. There are lots and lots of awareness dates within this sort of perinatal mental health space and more widely coming up in September and October. So we've tried to list as many as we could on this slide. But what I would say, which is going to be quite an exciting thing to look out for, is that I've just seen on Twitter recently in the last week or so that somebody's actually taken it on to make a sort of perinatal mental health specific awareness date calendar. So once that work's been completed, we'll definitely be sharing that with you, because there's so many different days that we could be highlighting in our different workspaces. Okay, the next one. So today we're themed around neonatal and perinatal mental health, and I think this is such an important area that I don't know if we've worked maybe as closely as we should have been. We know that mental health problems are more likely in parents that have had babies that have been poorly and been admitted to neonatal units. So I think this is a great morning for us all to sort of understand that space a bit more and work out where the synergies are and how we could work together better. And as a lovely start to the day, we've got Vicky and Holly from Bliss to talk to you about their amazing work. So I'll hand over to them now.
Thanks very much, Jenny. Hi everyone, my name is Holly and I am the Baby Charter Programme Lead here at Bliss, and I'm joined today by my colleague Vicky as well. So we'll be doing a bit of a double act in doing a bit of a presentation for you guys today. So if we could have the next slide, please. So those of you who haven't heard of us, Bliss is the charity that was founded in 1979 by a group of concerned parents who had concerns around the equipment and the staffing levels that were available at that time on neonatal units to care for their babies who were born premature or sick. And we've changed quite a bit since 1979, but our sort of vision and mission is still largely the same. So our vision is that every baby that's born premature or sick in the UK and spends time on the neonatal unit has the best chance of survival and quality of life. And we do this in a number of different ways. So we empower families, we influence policy and practice, and we do a lot of work with healthcare professionals, and we enable life-changing research and support research as well. So today I'm going to talk a little bit about the work that we do with healthcare professionals, specifically around the encouragement of better quality psychosocial support for families who have had a neonatal experience. And my colleague Vicky is going to talk about our direct support for families. Next slide, please.
Holly, are you able to put your camera on so we can see you whilst you're presenting?
Oh, of course.
Lovely, thank you.
Hello, here I am. So the first thing that I'm going to talk about is the baby charter that we offer at Bliss. And the baby charter itself, which I'll explain in a minute, is focused on an ethos of care called family-centered care, which essentially puts families and the baby at the heart of all care that is given on a neonatal unit. And it's there to sort of address the differences in parenting roles that come with having a baby on neonatal care, and it aims to help families and parents sort of cope with the stresses and the anxieties that come along with that. And ideally, we want this level of care to be provided at every neonatal unit across hospitals across the UK. And a way in which we try to do this is through the use of something called the Baby Charter. So next slide, please. So the Baby Charter itself, it was designed to standardise that ethos of family-centred care, which I've just explained, across the UK. So it exists as a practical framework for families, for neonatal units, to self-assess the level and the quality of family-centred care that they provide on their unit. And so units do this through a set of 7 different principles. So they work through, whoever's seen the Baby Charter will know that it is quite long and extensive. They'll work through loads of different standards and they'll provide evidence as to what they do on their unit, what practices are in place, what policies are in place, how they work with families to try and deliver this family-centred care. And it helps units to audit their practices and ultimately develop plans to improve their practice and achieve sort of better outcomes for babies and their families. So next slide, please. So the 7 sort of principles that make up the Baby Charter are here. So we look at decision making. So we look at if a baby requires a procedure, for example, how are the family involved in decisions around that? How are they given all of the information that's required in order for them to decide whether they want to be present at that procedure, for example? We look at specialist services and staff. So that could be people that look after discharge, feeding, mental health, psychosocial support, for example. We look at benchmarking. So how do units compare themselves with other units across their network or across the country? How do they use things like neonatal data to measure up their practices, for example? We look at information and support. So how do parents know where they can go to get a bite to eat? How do they know who to ask for parking? How do they know how they can access support and what support is available? We look at feeding, so how are families encouraged to build their confidence with feeding so that they feel very comfortable going home and having that support. We look at discharge, so how are families involved in those conversations? How are the multidisciplinary team involved in those conversations, getting baby ready to go home? And we also look at social, developmental and emotional needs of both the baby and the family. So in terms of developmental care, so how is the baby protected from bright lights, how from loud sounds, but also how are the family supported as well with things like their mental health. So next slide, please. So at the moment, the Baby Charter exists to support units to try and improve their practices, to create more consistency between units to ensure that units are providing sort of high levels of family-centred care, and ultimately to give better outcomes for babies and their families. So we've got over 90% of neonatal units in the UK who are registered to do the Baby Charter, and they'll be at different stages of the process. So they might have just registered and be beginning their journey, or they might have gone through the whole process and be accredited. So we've got 13 of those units across the UK who are accredited, which means they've gone through a quite rigorous and robust process of auditing, having assessment days. We'll go and visit their unit, chat to parents and staff. Every neonatal unit across the UK has access to this for free, so they can go onto our online tool and they can audit their practice, or they can sort of pay to work throughout the accreditation process. And throughout the Baby Charter, we work with each unit individually and we measure the positive changes that a unit is making when it comes to various different aspects of the audit. And that can be things like psychosocial support. So we can see that as part of the Baby Charter, we've seen people hire psychologists off the back of doing the Baby Charter, have members of their team undertake perinatal mental health training, introduce Facebook support groups, reintroduce family peer support groups after sort of COVID. So we've seen loads of positive changes that have come about the sort of psychosocial support provision off the back of units doing the Baby Charter. Next slide, please. But specifically, when we look at psychosocial support, we have some standards within the Charter that directly address this. So throughout the Baby Charter, we'll ask various things that we think support families with their mental health. And it can be things like access to chaplaincy on a unit, access to peer support, interacting with other families. but we have these specific standards that look directly upon sort of psychosocial support. So about whether families, including siblings, are offered that social and psychological support while they're on the unit, whether they have access to support from community neonatal teams, and that can be how they link up with house visitors, for example, and whether families are provided with written information about what's available in the community, so psychosocial support, advice, services, organisations, networks, including about how they can get in touch with those services. So we measure all units on these standards. That first one particularly is mandatory. So if that is not something that is provided on a neonatal unit, we can't progress with that unit with their baby charter. It's something that they have to evidence that they have on their unit. And we do this through having the support of a very, very fabulous advisory group who are all volunteers who work in a psychosocial capacity within neonates. So we've got some psychologists, some counsellors, some family support assistants, some psychotherapists, a whole sort of bunch of different roles there. And they review the evidence that a unit provides around these standards to support us in understanding where there might be gaps or where we can make recommendations. So for each unit, we have 2 of those volunteers who review this evidence. They might make suggestions or recommendations, and they often ask really important questions such as, you know, how do families self-refer for this kind of service? What happens to cover if there's a psychologist on the unit but they go on leave? How are parents informed about the service that you offer? How do they access support once they've been discharged home? So they often unpick that evidence and try and find out as much information as possible, and they also make recommendations for how that service and provision could be improved. And we hope that this sort of process is quite robust, and it really does work towards improving provision of psychosocial support across neonatal units. Like I said, our advisory group are amazing. We're so lucky to have them. We know that it's not a quiet job to work in that sort of area within neonates, so to give us their time is really valuable. So I'd also encourage anyone on the call today to think about if joining the advisory group might be suitable, or if they have any colleagues who might want to be part of this work as well. So that's a very quick introduction to sort of how we sort of champion psychosocial support within neonatal units. We're always looking to make further recommendations or improvements, so please do get in touch with us if you have any questions or if you want to make any suggestions. But that's the work largely that we do with healthcare professionals around that. And now I'll pass over to my colleague Vicky, who will talk more about the support that we offer directly with families. Thank you.
Hi, I'm happy to be here. My name is Vicky and I am part of the support team at Bliss. Next slide, please. Our aim is for babies born premature and sick to have well-supported parents playing an active role in their decision-making and care. We want parents to feel more confident in their roles, and to have families feeling more confident, we need to provide them with the information that they need. They may well have prepared for a regular birth, read the books, been on the courses, but very often having a baby in neonatal care is not what they're expecting. They find themselves in an unfamiliar environment, their baby's very vulnerable, and it can lead to parents feeling underprepared and then lead to a lack of confidence. We want parents to be better informed, so we have loads of information on our website if you want to have a look at that. And there's also a booklet for parents called About Neonatal Care, which should be available for free in our shop if you want to order some for your units if you don't have any already. We aim to make parents feel less isolated. Again, if you've accessed all the groups before during your pregnancy, you might have made a kind of peer group of support, but then you find yourself not within that peer group because your baby is in neonatal care and they're all at their regular clubs that they go to, and you're alone on the unit, feeling vulnerable and isolated. And then you get home, your baby might have equipment or particular needs or be particularly vulnerable. Especially right now, parents are more anxious about taking their vulnerable baby out in the community, and who's to blame them? So it can lead to people maybe being alone at home and feeling isolated, and then they can get in touch with us to help them in that. We also try and help parents become more involved in their decision making, making sure that they understand some of the things that might be happening in the neonatal unit, talking through some decisions that they might have to make. We would never give advice on what they ought to do, but we'll be a sounding board for them and maybe signpost them to other organisations that can provide some information if it's about a medical concern, making sure that they know that they can be involved in their baby's care. Not every aspect will be medical, and that bonding is extremely important and how they can contribute. Next slide, please. How we do this? Well, before COVID, we did it face-to-face with Bliss Champion volunteers on neonatal units. Bliss Champions are volunteers who may or may not have had a neonatal experience themselves, and they've gone through our training programme. They're regularly supervised, and they go into neonatal units and provide cot-side support, or they did prior to COVID. I'll get onto that in a minute. We have an email support service, which is hello@bliss.org.uk. If you want to get in touch with us yourselves, we'd be happy to hear from you, or point anyone our way, we'd be happy to respond. Again, I've already said we've got loads of information on our website, and we have publications which are about neonatal care and going home from the neonatal unit. Next slide, please. When we had to come out of neonatal units due to COVID, we set up a Bliss remote champion service, which I'll tell you a bit more about in a minute in the next slide. We also saw a rise in support emails, not unsurprisingly, and a lot of those were to do with restrictions and access difficulties and concerns about shielding. Those have died away now, but the level of emails that we're receiving is still high. We increased our social media output from the information and support team, and we have created a closed Facebook group. Again, I'll tell you all about these a bit more in a second. Next slide, please. So the remote champion service is where a family can request a one-to-one chat with a Bliss champion over Zoom, and it's about 30 minutes long. Sometimes they can run over. They can book it by emailing us at hello. Or there's a button on the website where they can just fill out a little template and we'll get back to them to arrange a time that's suitable. It means that we've been able to reach more people, because now we can support people at home as well. We can support people in the evening, we can support them at a time that's suitable for them, and we can also support other family members too. So that is still popular, and I was talking to some champions the other day doing supervision, and it turns out there's quite a lot of people who are at home with their babies, feeling isolated, feeling anxious, and they're able to receive that support now, which they wouldn't have been able to access previously. There's no limit on the number of sessions, although if we felt someone needed more formal support, we would support them to access that. And if you want some information on that, then you can go to our shop. The details of it are there. All the stuff is free and you can get the free postage as well, I think, if you're a healthcare professional. Next slide, please. These are about our email service, and this is just some of the things that we're asked. It varies every single day. There's hardly ever an email that is standard and that you can go, oh yeah, I can answer that one. So we work as a team to kind of address some issues that might have come up already. There are some things that we're frequently asked about bonding and feeding and different ways to be involved in their baby's care, and we have some podcasts about different topics too that parents can listen to while they're in the unit. Again, standards, we're asked about financial information and we signpost to specific organisations for those. But largely it's more emotional support that people are looking for. Next slide, please. And how we respond to those emails is I don't know why listen is second actually. I should have put that at the top because that's what I think is the most important thing about the service. People sometimes will write an email and it's almost as if they've purged themselves of all the thoughts that have been worrying them. So I think it's really important to listen and acknowledge what people are saying. We also try and share some helpful information that might be practical for them, things that they can do if they're feeling helpless. We'll signpost to some of the services that we have if they think we think they might benefit from speaking to a champion or from some peer support from others, and to other helpful organisations that we link up with. And a week later, we send a follow-up email just to check how they're doing, which I think is nice to create that bond so that they realise it's not a service just for them now, it's a service for them as their baby develops. If they want anything, they can get back in touch. And it's nice when you recognise a name and someone does do that. And those things there are just some of the things, again, that people ask us about. It's endless. I could have done 5 or 6 slides, but it's just a few examples there. Next slide, please. And again, this is just some of the information we have on our website about neonatal care, how to get involved in your baby's care, mental health information, medical conditions. These are like whole sections, some of them with links to other organisations. We also have, which isn't on here, and I should mention, we have a section on RSV now. We received some funding last year, and we did quite a bit of work on RSV. We've trained our champions to know more about RSV when they're talking to parents. There are some animations on our website in a range of community languages, which might be useful as well. It's a way of making parents aware of what to look out for and when to seek some support. There's the printed information. I've already mentioned the 2 booklets that we have, and I've mentioned our podcasts. So one about looking after yourself, basically, and one about looking after your baby. But please have a look, and if you can't find what you're looking for, then get in touch because it will be there and we'll find it for you. Next slide, please. Yeah, we increased, when we didn't have direct access to people going through their journey, we increased our social media presence. So we have about 2 to 3 support and information posts that go out on Facebook, Instagram and Twitter each week. We've also done, we joined up with PND Hour and did a session with them on Twitter about mental health. We did an Instagram live recently with Little Lullaby. So we've kind of been increasing that so that we can make sure and access people as increasingly people are using the internet as a form of support. We also, it was about 3 months ago, we set up a Facebook group. It's a closed Facebook group and it's for parents who are going through or have had a neonatal experience to support each other. And we have got 150 members now, which is not bad going considering we don't even have a poster yet. But when we do, then please look out and we will be sending them to neonatal units and anybody else who thinks it would be useful, health visitors, for instance. If you think it would be useful for parents to access that kind of support, we'll send you a poster when they're available, because it's our only service where parents can speak to someone who's definitely been through a similar experience themselves. Some of our champions may have been, but our champions put the focus back on the parent who's going through their own experience. They don't really talk about their own if they've had one. Next slide, please. And this is just a little bit of feedback from parents to round off. One is about Facebook, about how they know that they're not alone. Another one is about how they like the information that we provide because it's simple, easy to understand. If you're in the middle of a very traumatic situation, you don't want to have to be Googling what something means. So the information on there should be easily understood. One about champions who offer very practical as well as emotional support. They're really wonderful and very experienced. And the first one on the left is my favourite though. And I think it's about hope. So much of the stuff that I read, I've been in post for about 1.5 years, a bit more than that. So much of the stuff I read about babies born premature or sick was negative, didn't give an awful lot of hope. And I like to think that our information and our support does offer that little bit of hope in a time when things must seem very worrying and not necessarily filled with hope. And I think that's us. I think next slide will just say thank you. Yep, and any questions either now or there's our email addresses if anybody wants to get in touch. We'd be really happy to hear from you.
Oh, thank you both. That was so amazing to listen to. It's such a great charity that you have, and I'm sure that it must comfort so many people. And amazingly, especially for me, we're bang on time. So can I suggest, if you two don't mind, that any questions, immediate questions, go into the chat and you can answer them in the chat? Is that okay? And then we'll actually be on time, which is quite unusual for me, I have to say. So thank you very much for that.
Thank you.
And what an amazing organisation. It's just so good what you guys do. So thank you for that. Okay, so I'm going to move us on, bragging again about actually being on time today, which is amazing. And it gives me great pleasure to introduce Dr. Jacinta Caldwell and Dr. Siobhan Higgins, who are going to talk to us about developing psychological services on neonatal units. So it's really interested to hear from you two about this work. So thank you very much. Over to you.
Brilliant. Thank you very much. So as Joe said, my name is Jacinta Caldwell and I'm a psychologist and lead for the neonatal psychology service for Thames Valley and Wessex Neonatal ODN. Some of you may also know me in my lead role as lead psychologist for the neonatal unit at the John Radcliffe Hospital in Oxford. I'll pass over to Siobhan to introduce herself.
Morning, everyone. Really pleased to be here. My name is Siobhan Higgins and I'm clinical psychology lead for Kent, Surrey and Sussex ODN.
Great. So really thank you for the invitation to present today. It's really great to come and be able to kind of share with you some of the work that we've been doing since in our new posts, and really to bring awareness and context, I think, to the needs of neonatal families. So if you can go to next slide, please. So just to kind of give a bit of an overview of what we hope to cover today, we really don't have long at all, and we could probably fill a whole day and what we would like to say. So this is going to be a really quick whistle-stop tour. I guess we wanted to provide you with a brief overview of kind of neonatal units and their broader context, and so that you can understand some of the work that we will be presenting. We want to be thinking really about what being on a unit is like for babies and their families, and some of the themes related to the working psychologically on units. We want to really then focus in on some of the kind of recent national changes and drivers, and to focus on our roles as psychology neonatal network leads and what we've done since coming into post in January and what our future plans are. Next slide. Thank you. So just to think a little bit about kind of the neonatal context and the babies that are supported by neonatal services. So across the country, there's on average, about 50,000 babies admitted into neonatal care and onto neonatal units each year. And so that represents about 9% of all babies born. And I think quite contrary to belief, because often there's a belief that it's mostly premature babies. Actually, only 50% of babies in neonatal units are premature, and there is a whole host of other reasons for why babies might be there. So some of the typical reasons could be early birth, either planned or spontaneous, babies born at low birth weight or with jaundice or hyperglycemia, babies born requiring surgery or with congenital abnormalities. Some babies may have respiratory conditions or cardiovascular disease, and some may have not had enough oxygen during the birth process, and they go on to develop a condition known as HIE. So the reasons are really quite varied, and some babies only require a short stay on a neonatal unit, and some are on neonatal units for weeks, months, and occasionally longer. Thank you. Next slide. So over the past 20 years, neonatal services and units have been organised into networks of providers that work together really to deliver care. So there are 10 neonatal ODNs who are commissioned by NHS England's Specialist Commissioning Team. And these really have a mandate to develop and implement programmes of work to improve access to specialist resources, to improve neonatal outcomes and patient experiences, working closely with both providers and commissioners. So the ODNs work closely with LMNSs to ensure high quality care is provided, and that is really responsive to the kind of needs of women and babies, but also kind of maintains care as close to home as possible. Neonatal care is currently delivered in 156 units across England, and there are 3 types of units. So we've got 43 neonatal intensive care units, and this is really our highest level of support for babies born from 22 weeks gestation and requiring significant support. We have 75 local neonatal units, and these usually take babies from about 28 weeks gestation. And we've got 38 special care units, and the typical gestation for those units is around 32 weeks. So each network will have a mixture of these three types of units, and also the care that's offered within each of the units. And babies can and do transfer between units, and I think that's really important, because actually what we often find is that families are often far away from home. They're displaced from their social networks, their home environment, the things that they're known to them, and so they are having to really adjust to being in a new place in a very difficult time in their lives. So I'm just going to pass you over to Siobhan.
Next slide, please. And thank you. So we just wanted to highlight the area of intervention, psychological intervention in the neonatal units as something that certainly has overlap with perinatal work, with parent-infant work, with paediatric and health psychology, and with CAMS work, but equally is an area of clinical specialism that does require additional thinking and more specialist thinking for the specific needs for the families, the units, and the babies. Next slide, please. And we're very aware that that the experience for the parent, the infant, and for the staff is extensive, and thankfully our Bliss colleagues have given us a slight introduction to some of that, but we just wanted to highlight some of the themes to make you aware of some of those ideas and what those experiences are. So for the baby, they're born too soon or born sick. This really wasn't how life was meant to be for these little ones. They're born with sensory vulnerability, their brains aren't fully developed, their organs may not be fully developed. They experience multiple interventions from the outset. They can experience a lot of pain. There can be risk to their lives. They're also experiencing separations from that early point in birth. From birth, they can have multiple caregivers. They might not be with their parents for very much, often isolated in their incubators on wards. And that's their experience being met by parents who are also very vulnerable, who've potentially experienced a traumatic birth. This just wasn't how life was meant to be for them as a family. So thinking specifically for parents and for families, we know that levels of trauma, anxiety and depression are high, and often highest in this particular group. They're managing fluctuations in the baby's physical presentation, and there can be an ongoing adaptation to diagnosis, to potential disability. There's that very much interrupted transition to parenthood. It can be abrupt, it might be planned for, but again, it's quite different from this imagined future a lot of parents had expected. And just linking to that idea of separation, there's that inability to claim the baby. Nurses will be involved in their care. The parents may not be as much, even though certainly that's something the units are very keen to promote. It's very different from what this image or imagined future had been for these parents. They're often a visitor to the units, and that can be heartbreaking, actually being in that particular role and then going home at the end of the day. And then the challenge for a lot of our parents, witnessing multiple interventions, fluctuations in health, weight, and dealing with that potential loss can be very challenging, alongside making difficult decisions around their baby's care, alongside supporting other siblings and other family members at the same time. We're very much aware that all of this can have a significant impact on staff as well. The vicarious trauma of having to witness all of this in the parents and the babies that they look after. The burnout levels are high in neonatal staff, and there's that sense of moral distress. They might not be able to care and offer at a level that they want to, and they become very involved and equally attached to the parents and babies that they work with, and that loss and grief when a baby may die, alongside the fear of litigation, which is also real for a lot of staff, but then might put them in a position of not getting involved for at an emotional level because of that challenge that might be there. And all of that coming together may mean that there's less time and emotional capacity to provide psychological support at a universal level for these families. Next slide, please. So when we think about intervention for our families and for staff on the neonatal unit, what does that look like? So again, when we're thinking about the baby, the individually as an infant, we want to think about trying to voice their experience, both to their parents, both to the staff team, and trying to have, encourage that thinking and awareness of what the baby's experience is for the people around him. And then also thinking about the parent-infant relationship, looking at the baby's cues, supporting parents to be involved, but also working with parents when there's a challenge with that and what might actually be getting in the way, and how we can both support both parent and infant to be more connected. And it's interesting that that's come up as a challenge with our Bliss colleagues, so that's certainly reinforcing in some of the work that we do, but very much working alongside our AHP colleagues to think about babies' development, who will be picking up on elements of a lot of this as well. Then for the parents and families themselves, working with the trauma, the anxiety and low mood live and in the moment, but equally trying to mitigate the experiences of what we know is a very stressful and difficult experience at that time. It's not normal to have your baby to experience a neonatal admission, and we want to try and prevent the long-term implications of that. And then supporting parents with adjustment, fluctuations, diagnosis, but also whether it's kind of a real or imagined fear of the future. And that can be quite a challenging journey. Decision making, as we've mentioned, but also bereavement, unfortunately, if a baby dies. And then also involving and supporting siblings is very much part of the thinking that we want to do, even though obviously that's been impacted by COVID. And then thinking specifically for the staff team, thinking about reflective practice, case consultations, and helping to try and mitigate the impact of the emotional experience of the work, the opportunities to really think with staff about complex cases where there might be quite challenging emotion to work with that can play out amongst the staff group, but also being involved in staff training and inductions to really support the kind of thinking around the family's touch points, which links into the idea of being involved in the systems and culture that's available and that supports families on the neonatal units, that the units are psychologically and trauma informed, and that kind of context and thinking is part of every part of the baby and the parent's journey on the neonatal unit, through policies and procedures, but certainly informed through experiences of co-production that then can feed into training and education for the staff. Next slide, please.
Thank you, Siobhan. So I hope that that's given you some idea really of the needs of babies, families and staff, and how we might work with that psychologically. And I think it's been long recognised that having a more holistic approach to neonatal care that kind of includes the physical, psychological and emotional needs of babies and families is really important. But it's actually only really in recent years that this has been turned into action. And so this slide really speaks to how we've got to where we are now, and thinking about the national drivers for change that have led to neonatal network strategic roles across a number of different disciplines, including psychology. So there's a number of key documents over the years that have really spoken to the need for more family-centred care, and these include the Toolkit for High Quality and Neonatal Services, the Poppy Report, both of those published in 2009, and also BAPAM's service standards for hospitals providing neonatal care in 2010. However, it's been nearly a decade later with the publication of the Neonatal Critical Care Review, so the NCCR, that the importance of a wider workforce of including AHP and psychology roles have really been turned into specific action plans for regional commissioners, ODNs and LMSs, really to kind of think and make plans about service change. So one of the key findings of the NCCR was the lack of dedicated AHP and psychology provision across neonatal units in England, and that was subsequently been highlighted by the GIRFT report. Next slide, please. So the GIRFT Neonatology Review was really designed to complement the Neonatal Critical Care Review, just really providing kind of additional information in key areas highlighted by the NCCR, including kind of capacity and patient pathways, family care and their experiences, but also thinking about the neonatal workforce. It's a really long report, so I recommend that you read it. We are happy to send out a link with this presentation later if that would be helpful. But just a few of the kind of key recommendations we've got here. So this is obviously national figures, but 63% of units nationally have no psychology services. And actually, interestingly, really notably, 41% in our NICUs. I think this is obviously I've mentioned that these are national percentages, and from our scoping, so obviously myself and Siobhan work within Thames Valley and Wessex and Kent, Surrey and Sussex ODNs, which is probably the footprint more within the South East. We noticed that 65%, so 9 out of the 14 hospitals within Thames Valley and Wessex have no psychology service. And in KSS, actually only 1 unit has provision, so 92% of their units have no psychology provision. So the GIRFT report kind of pulled out a number of key recommendations, including increasing awareness of neonatal family experiences, to write neonatal psychology staffing standards, to undertake gap analysis and really to kind of support with business cases for improved provision, so that psychological support should be developed and available for all families. And I think that feels quite different to maybe how some services within the community have been kind of set up. And as Siobhan has very helpfully said about creating this kind of more psychologically informed environment. And the report specifically talked about kind of developing referral pathways to community mental health and developing links for peer-to-peer support. So many of the strategic aspects of these recommendations have really been turned into key objectives for the new neonatal network psychology lead roles that Siobhan and I now hold. Next slide, please. So as previously I mentioned, these are strategic roles, and this really slide highlights a number of these objectives that have come from some of these key reports. So there's naturally going to be some variation in local priorities across networks, but hopefully the slide just gives you a bit of an overview of what we are and will be working towards. We don't have time to go into all of these today, but I think what we'll do is we'll speak to the main ones that we've been in focus for us kind of currently. In brief, though, these objectives are around kind of education for the workforce, scoping and mapping links to community services, building and sharing resources within neonatal ODNs, thinking about providing opportunities for consultation and shared learning, and to be thinking about how do we support those that are already on the ground through peer supervision, scoping and building the neonatal psychology workforce, which we've been working on quite a bit over the last few months, and really to be thinking just about how do we establish research priorities and to undertake evaluations and audit. Next slide, please. I'll hand over to Siobhan.
Thanks, Jacinta. So just want to introduce you to our other psychology lead ODN colleagues up and down the country. I know there are some people from different parts of the country that are on the call. So Jacinta and I hold the role in, as we said, Thames Valley and Wessex and Kent, Surrey and Sussex are covering the southeast. So we are part of a group of 10 and work quite closely together on the initiatives and helpfully we're really able to then provide and work with the philosophy of both the GIRFT and the NCCR recommendations in developing parity of care and clinical competencies that we want to think about nationally, and hopefully reduce the ideas of postcode lottery going forward. But certainly having good links together means that that as services develop, they're developing together across the country. Next slide, please. So to think a little bit about, what we have been involved in so far, obviously a main theme and driver for us is to think about education. We've been encouraged by Health Education England to think about a national e-learning package. We're going to focus initially on support for the neonatal workforce, and to think about the psychological experiences, both for families and staff, to support that thinking going forward at a more universal level. Hopefully over time, if there's more funding available, we'd then like to move it to a next level once we hope that our business cases may be successful and we've got more staff on the ground, that we can think about building that knowledge and staff for psychological therapists who are newer to work and within the neonatal units, and developing their understanding and capacity going forward. We also want to think with our local educational leads to think about the current educational modules and preceptorship programs that are available for nurses, and also are available to develop on the ground teaching that we can deliver locally, and that's where we want our next focus to be. Next slide, please.
Can you just give a 2-minute warning as well, please?
Okay, thank you. So also to just give you a bit of an update on what we've been doing so far. So we've been quite active in visiting our units and building relationships with our local colleagues. We've been scoping current provision and developed a gap analysis alongside our newly developed staffing standards, which weren't developed when we came into post in January. We've also been liaising with NHS England, the National Implementation Board, thinking about our staffing standards and the funding opportunities which may be available to us, thinking about what might be coming out of the Ockenden report. And we're also beginning to think about business cases locally, to think about what that local provision could look like, and are keen to try and develop that moving forward. Next slide, please.
So I'll try and be brief with these. So I guess a key thing for us was about supporting our existing neonatal psychologists and therapists that are already in place, and really setting up peer supervision groups for colleagues, which we've just started to do. A key recommendation from the GIRF was to develop our staffing standards, and that's really what we've been spending quite a bit of time over the last couple of months trying to do. These have now been written and they are out with the BPS, the Association of Clinical Psychologists, BAPAM, and the NNA, which is the National Neonatal Nurse Association, for endorsement. And obviously we'll be looking for support from that from other organisations. A part of it, and the next step really is beginning to think about and develop specific competencies for neonatal psychology workforce. And we're really drawing on the learning and precedent set by our perinatal psychology colleagues, but also learning and developing from those in the US that are a little bit further along in their neonatal psychology work. So, and I guess the last point really is in just recognition of the request of support we've had to understand neonatal families' experiences for other services and groups that we've been able to kind of contribute to. Next slide, please. So in our work as ODN leads, we're in the process of collating and developing a number of resources that can be shared across neonatal units. We're also keen to collaborate with local needs to think about research and evaluation, and how do we capture staff and families' experiences to provide meaningful information. And lastly, just we think we've been working quite a lot on kind of network specific work streams, so things like developing parent passports, guidelines, and other sorts of parent leaflets and resources. Next slide.
So just to give you a flavour of where we are now and what's coming next, and we're really keen to present here, because hopefully that'll give us a springboard to think about what's available in the community, but both within the NHS services and in third sector, to help us think about care pathways for some of our families post-discharge. And that will also involve linking more directly with the LMNSs as well. So we're really keen to present. We also want to think about workforce development. As Jacinta said, the competency framework is going to be a next priority for us, and we want to work with our psychological therapy colleagues on what that looks like moving forward, developing business cases, job descriptions and person specs. So hopefully that's all ready. Should any funding be released, we can capitalise on that. And then education is also going to be a key area of focus for us. We're keen to do a training gap analysis for psychological thinking, and also referring back to the HE modules for e-learning. Next slide, please. So yes, we just want to say hello, and we're available to you. You've got our contact details. Both Jacinta and I, probably more Jacinta, are quite active on Twitter, just to let you know what we're doing currently and live. And please be in touch with us. We're really keen to make links with our Southeast community and be available and link into the idea, as Jenny and Liz have said, to be more joined up, and hopefully we can try and support that. Next slide, please.
So yeah, just a thank you, and also thank you to our national team. That obviously we've been collaborating on some of these pieces of work. Sorry, we ran over.
Thank you so much. You've ruined my hat trick of
I'm
getting
sorry.
everybody home on time, but that's fine. Very interesting and lovely to see how many developments in that space. There are a number of questions in the chat, so if I could ask for all any other questions as well to be in the chat, if you're happy to answer the ones that are already there, and I will, without further ado, move on to our final speaker for the day, which gives me great pleasure once again, and thank you so much to Minesh for coming to talk to us. So Minesh and Elizabeth and I have worked together back in the day when Minesh was clinical lead for the maternity programme, and now I'm delighted to welcome him today to present about a specific area of neonatal, which is about dads. But knowing Minesh, there'll be lots of extra lovely things woven into it. So without further ado, I'll hand over. Thank you very much.
Thank you, Jenny. Thank you, Liz and Yvette. Can you see my slides and can you hear me well?
Yes, thank you, Minesh.
Okay. It's a great pleasure to talk about this topic, which is quite close to my heart. To those of you who don't know me, I'm Minesh Khoshu. I'm a neonatologist and professor of perinatal health at University Hospitals, Dorset. My Twitter handle is at the bottom there. I found Twitter quite useful in terms of networking and being aware of recent developments. So if you're not on Twitter, I suggest you give it a go. Before I go into the fathers bit, which is the main focus of my talk today, I wanted to highlight this recent article, which is a meta-analysis and review of 56 studies. And the take-home message for all of us here is that there's a high degree of mental ill health, anxiety, post-traumatic stress in parents of babies who are in neonatal units, almost 50%. And this high need for support exists almost for the whole first year of life. So first take-home message for all of us is, how do we ensure that there's good surveillance of these parents during their neonatal stay and all through the first year, and what different levels of support can we offer them and keep an eye on things at least for the first year of life. So important recent addition to the literature, which shows evidence that we need to do a lot more work to support these parents. Coming on specifically to the talk here, we understand that perinatal mental health, especially for parents whose babies are sick or preterm, both mom and dad need it. The conditions for moms is not great either. But as alluded to before, I'm going to focus on fathers, largely because in a lot of ways we find that there are a forgotten lot. And I'm going to focus not just on fathers' ill health, but more on how we can engage with fathers better, how we can improve their experiences of the neonatal perinatal pathway. These are some lovely pictures courtesy of UNICEF, which show how important and fulfilling fatherhood is for fathers when their babies are on the neonatal unit. And in the next 15, 20 minutes, what I'm trying to focus on will be what is the main aim of my talk, why I think it's important to focus on fathers' experiences. We may not have time to gauge your views on the current situation, but if you have any specific thoughts, please put them in the chat. And I'm sure Liz and Jenny at the end will highlight those. I'm going to leave you with some potential improvement change ideas and some hopefully useful key take-home messages as well. So the main aim is to improve your understanding of current experiences of fathers, to share some best practice examples with you, and obviously stimulate you when you go back to your units, your services. You can initiate and sustain some improvement change ideas. To start off with, I guess the first question would be, thinking about fathers' experiences of neonatal perinatal care, what words come to mind? And unfortunately, the way I'm presenting, I won't be able to look at the chat, but I'm sure my other colleagues will keep an eye on this. But generally, when I ask this question of audiences, the common answers are quite negative, which again highlights the need for talks like this and highlights the need for raising awareness. And again, a self-assessment, so to say, how would you rate your own unit, your service, your hospital? And again, an important milestone in thinking about this for your own unit and service. And then once you decide how you rate your service, you can then decide if you're rated high, why it's high, if you're rated low, why it's low. And this is part of your own sort of path in terms of improving fathers' experiences. I'm going to leave you to read these quotes, which are real quotes that fathers have quoted as part of their neonatal journey. These quotes largely highlight the magic of fatherhood of parenthood, but also, if you look at the last quote at the bottom there, the fact that a lot of times fathers in perinatal services and maternity neonatal services can feel left out. Some of these quotes also highlight that the way society programs us, a lot of fathers almost feel the need to put up a brave face in front of their partners, in front of society, their friends, family, and it's difficult for them to really express their own feelings. And talking about social expectations, we understand how important a role they play, not just in terms of fathers reacting to some of these situations, but also how we as healthcare professionals react or interact with fathers. There are some attitudes which perhaps need to change, or perhaps gradually changing, but perhaps need to change faster. Things like employment at work are mainly a man's responsibility. Women are better at caring than men, and men should be strong. And strong, again, within inverted commas, it doesn't mean that if you express your feelings, you're not strong. Another key take-home message from my end to you all is this important bit, which is that father-baby attachment has a biological basis similar to what mother-baby attachment is, but it has not received adequate attention. So there's enough evidence, if you look at neurobiology, to show that fathers change in relation to the birth of their baby. Their changes in their hormone level, their changes even in their brain structure. So I think it is important when we work in this domain, we understand the physiological and the biological changes that happen. When we talk to fathers, especially in the perinatal setting, these are some of the unmet needs that fathers sort of share with us. They sometimes don't have direct contact with the healthcare team because they're not there all the time, or they might be gone back to work. They find this perhaps not a consistent, reliable information for them. They find that there isn't parity with how the neonatal and perinatal maternity teams sort of engage with them between say moms and dads. And there's lack of support tools in terms of fathers specifically. This is a review article we as a group published a few years back. This is part of a group called Finesse, which is an international group which researches fathers' experiences, and I chair this international group. So we looked at the literature a few years back and asked ourselves, what does the literature tell us about fathers' experiences of neonatal care? And following that, we came up with some key principles and some key recommendations for change or improvement. The first principle was that the father-baby bond should be supported in the same way as the mother-baby bond. The second bit was that we should pay attention as service providers, as healthcare professionals, to differences between mothers and fathers. And the third bit was we should be supporting a co-parenting paradigm. In the way we deliver services. So these were the three core principles, and it's important you take these back to your unit with the following recommendations. And these recommendations were assessing the needs of mother and father individually, looking at them individually in care plans, ensuring there's complete flexibility of access for fathers who might be gone back to work, and gear parenting education, as I said, towards co-parenting, focusing on the father-baby bonding, being attentive to the fact that fathers might try to hide their stress, inform fathers directly, not just through the mother, facilitate peer-to-peer communication for fathers, differentiate and analyze by gender in service evaluation. This is quite important, and I think this is important for Bliss and similar organizations as well. Train staff to work with fathers and to support co-parenting. Develop a father-friendly audit tool for neonatal units. Again, as part of the Bliss tool, there needs to be similar tools which are not just parent-friendly, but have specific questions with regard to fathers as well. And we're currently going through some work on the last bit here. So what I'm trying to say that we need some degree of a paradigm shift where there's parity between the father-baby bond, and services are geared to especially look out for fathers and support them. Based on what I've just shared with you, I think it would be useful to have your initial thoughts, and I'm sure some initial thoughts will go into the chat. I'm happy to have separate discussions with you if you so wish. My contact details will be provided with this presentation. And it's important when we see the literature, when we look at the deficiencies, at the gaps, then we ask ourselves what are the key areas of work, and these key areas of work will be similar to in different units, but there will be particular areas for your own unit or service that you would need to focus on, which may not be the case for some other units as well. So you need your own plan for improvement. So I've discussed this, assessing these needs individually. I think the care plans is an important bit as well. I'm not going to go into detail, but these slides will be shared with you. Accessibility to the neonatal unit, especially for fathers, was really, really bad during COVID pandemic. And we actually did a study as part of the Finesse group, which looked at how COVID-19 restrictions impacted the psychological well-being of fathers with infants admitted to the NICU. I don't think it's going to be a surprise to any of you that we didn't globally do well at all. I think while we need to applaud ourselves for the great work we all did during the pandemic against very difficult odds, I think a definite round of applause for all of us. We need to pat each other's back for some great work. Having said that, this was a big failure for all of us in terms of not really finding a way to improve the access for parents during the pandemic. I feel as a neonatal community, we let our parents down, especially our fathers down. Again, I'm not going to go into detail. When you look at your service evaluation, look at gender as well. Look at how father friendly you are. And I'm going to now share some good examples. One of the ones we did some good work a few years back, and these are dads who helped us make a lot of the content for the Dad Pad, which is a support tool, a communication tool for fathers. It looks like this. We're in the process of making an app version as well, but we still want a physical copy because it's supposed to be like a memento of the neonatal journey. I don't have any financial stake in the product. My job was to sort of develop it as a quality improvement initiative. It's been done through a company, which again is a community interest company, that they're not there to make money. But there's a cost attached to the provision of the Dad Pad Neonatal. And it has different aspects to it, which talk about your baby, the initial few days, what are the common conditions, who are the different staff. But more importantly, it focuses on the father, how the father is feeling. There are places for them to write about their emotions. There are places for them to write about incidents. They can put in some pictures. So it becomes like a keepsake or memento of their neonatal journey. The idea is to use the Dad Pad as a communication tool, as a way to start conversations with the father rather than just handing over them the Dad Pad and saying get on with it. So I think it's important we use the Dad Pad neonatal in the proper way. And again, some of the detail I'm going to leave for you to digest later when you look at the slides. There are some other good examples. There is an SMS for dads set up in Australia where they get messages regularly, a lot of them positive messaging to fathers. And similarly, some of the other ones I've listed here. Fatherhood Institute in the UK itself has done some great work, and I'm going to share some recent work with you from them as well. So as I said, this 2 hours father group in Australia, again, found quite useful and good peer support and very good feedback. This is a recent report. If you haven't come across this, please have a look at it, from the Fatherhood Institute. And it talks about how UK fathers feel during the first year of life, how well supported they are. This is not only about fathers whose babies are on neonatal units, but it's a good summation of our current evidence and our current provision. So in terms of take-home messages, I would want to come back to our 3 key recommendations from a review of the international literature and the 12 practical recommendations for practice. And I hope you take these and look at your own individual unit, your own service, and find ways to improve the experiences of fathers, which definitely needs improving. This is a take-home message for you and your teams. I'm going to let you read it. It says advice from a patient, but it's really advice from a parent. It fits in quite well. Compassion is the most important thing we can bring to work every day. I think we get busy, we get a lot of frustrations at work, but the first and foremost thing that we need to focus on is compassion towards our patients. So this is really an important take-home message for all of our teams. And an important take-home message from me to you is this one. So as they say, lukewarm is no good. So drive towards your vision with full throttle. And I'm gonna open it up for questions. Thank you very much for patient listening.
Hello, everybody. We've literally got 4 minutes. So if I say thank you to everyone and just remember the difference next time with the webinar being a little earlier in the month and the original date being cancelled. So having said that, I know there's some questions in the chat, and also Minesh is still here if anybody wants to ask a quick question in person. But thanks to all for coming. Minesh, I hope you can just answer some of the questions in the chat. I can see one. There's a couple about DADPAD specifically, and the DADPAD link I think was on your slide. So if you haven't got time to answer that one, I know people will be able to email Julian and find out costs and things. But there's one here from Joe Spores about recommendations translating to perinatal mental health as well.
Yeah, I think I'm happy to look through the stuff, though I'm struggling to find the exact one. And Jenny, you are highlighting. I think there was a question about DADPADs in general and DADPAD neonatal. DADPAD neonatal is separate, but it depends on what your contract with the company says. So I think in some places they've been included in the whole package, in other places not. So I would go back to them, but if there's any difficulties, please contact me. Any other questions, Jenny?
Yeah, there's this one from Joe, which is about should perinatal services. I wonder if you think there is further commissioning need that could be placed with perinatal mental health teams for focused perinatal mental health work and attachment and bonding work with fathers, because obviously the latter wasn't in the long-term plan ask, was it?
No, I think that's definitely the case. And if you look at some recent literature, especially from Canada, so especially in mums who have perinatal mental health issues, the risk for fathers is 5 times the average population risk. So there's a huge need, while we're trying to improve the mental health or perinatal support for mothers, there's a huge need to do that. So similarly for fathers. So definitely there's a commissioning need, and there's a need for us to have a good surveillance mechanism as we engage with fathers during their journey.
Thank you. Do we know if the scoring tools for things like attachment and bonding, do they translate okay for dads? Do we have any work in that area?
I don't think, as far as I know, but I'll need to check this and come back to you, Jenny. I don't think there are necessarily well used validated tools. I think people have used some of the other tools that sort of are traditionally used for mothers, and again there's perhaps a need for more research in this domain.
Thank you.
Thank you once again to all our speakers today. It's been lovely to see everybody. As Jenny said, just a reminder that the next webinar is obviously on the 9th of August and the 24th of August is cancelled. Our future dates are up on the slide. And just lastly, a reminder that if you're not on the distribution list, to email our generic inbox and request that. Okay, without further ado, wishing you a great rest of the day. Take care. Bye-bye.